Hello, this is Martin Altersberger speaking from Heart and Lungs Ultrasound. Today we are going to discuss the interesting but complicated topic about diastolic dysfunction. Why? Well, diastolic dysfunction, even though the guidelines are rather old, they're from 2016, there are some new developments, especially by means of strain imaging, which I think should be discussed. So the topics we are going to discuss in this lecture series is what is diastole. We will talk extensively about left ventricular and left atrial mechanics to understand them, the time intervals we should discuss, and especially where to measure them. So we are going to talk about the E wave, the A wave, and IVRT, and so forth. The measurements that can actually be done and what kind of information do they add about filling pressures and diastolic dysfunctions. We want to also know the pitfalls which are existing for the individual measurements. There are also plenty of formulas you can use to calculate not only the systolic pulmonary arterial pressure, but also the mean PAP, the diastolic PAP, the pulmonary vascular resistance, the left ventricular and diastolic pressures, and the pulmonary capillary wedge pressures. We also will discuss again what our current guidelines say and how to grade diastolic dysfunction. We will also discuss when we think that elevated filling pressures might be present and when it explains symptoms of our patients. Furthermore, we will discuss features of the left ventricle, the left atrium, but also of the right heart to identify problems there. And we will use plenty of measurements how to utilize the tricuspid valve, tricuspid regurgitation, and the pulmonary valve for also using those formulas. Furthermore, we will talk about more signs of elevated filling pressures, such as the presence of an L wave, the configuration of the L wave, the pulmonary venous flow. Also, we will discuss about the venous access ultrasound grading system to identify venous congestion. Furthermore, and this is one I want to mention specifically, is that we will talk about left atrial strain in evaluating filling pressures in diastolic dysfunction. And of course, we will share many cases and discuss filling pressures with you. But first of all, I have to understand what is diastolic dysfunction. It is a combination of inadequate filling in combination with a pathological relaxation of the left ventricle. So it's a left ventricular problem, but also a left atrial problem, because left atrial function will be reduced and the resulting elevated filling pressures are needed to ensure that there's still an adequate stroke volume and an adequate cardiac output. So why do we measure it? Of course, it is a form of heart failure. Heart failure with preserved ejection fraction is defined by measurements of diastolic dysfunction. Furthermore, it helps us in identifying heart failure patients who have dyspnea, patients with edema. It adds prognostic information in patients with heart failure with reduced, mildly reduced, and also preserved ejection fraction. And furthermore, we will be able to explain why a patient has a reduction in exercise capacity. Well, is it semantics, diastolic and systolic heart failure? Overall, let's review what heart failure actually means. There's heart failure with reduced ejection fraction. So heart failure is defined by ejection fraction, and the HFrEF is defined by an ejection fraction below of 40%. Then we have the entity of heart failure with mild reduced ejection fraction. It's an ejection fraction of 41 to 49%. And of course, we have the HFpEF, the heart failure with preserved ejection fraction, where ejection fraction is above or 50%. So when do we have a heart failure with preserved ejection fraction? Well, we have those small and stiff hearts, the typical hypertensive heart disease, hypertensive ventricles. When we have a systolic dysfunction, not only by means of ejection fraction, we will also have a diastolic problem. And when we have atrial dysfunction, we also do have diastolic dysfunction probably present that results in an elevation of filling pressures. And now is the HFpEF, the heart failure with preserved ejection fraction, a basically easy diagnosis. We have several steps. First of all, we have to think about the clinical signs and symptoms of heart failure. So dyspnea during exertion, fatigue. Now, who has never been dyspneic, especially, for example, when you climb stairs during 25 hours or longer night shifts? Do you never feel tired? So those are very unspecific symptoms. So next, we want to see how is ejection fraction. So we have to perform echocardiography and HFpEF with those clinical signs and symptoms with an ejection fraction of above or 50% is probably HFpEF. So who of you has an ejection fraction of above 50%? Well, I know that I do. So basically with feeling tired, feeling dyspnea on exertion, we already should treat the patients with diuretics. This is a class 1 recommendation. Also treat CV comorbidities. But in this case, who with that findings, the clinical findings, and only the ejection fraction above 50%, who wants actually diuretics? Well, I surely don't. And here we have some more diagnostic criteria about how to define if a HFpEF is present. But I want to move on because we have now some treatment options. It is for me essential and important to understand that diastolic dysfunction is often associated with also a reduction in longitudinal function of the left ventricle. And it's a really left heart disease. So if the left ventricle, the left atrium is normal, the presence of diastolic dysfunction, especially with elevation in filling pressures, has to be discussed. Furthermore, when you have a systolic dysfunction, the diastolic dysfunction will also be present, but not necessarily there are elevated filling pressures, measurable or existent. But not every diastolic dysfunction is automatically a heart failure or signs of heart failure. And what is important to discuss and important to understand is, are there truly elevated filling pressures existing? When there are elevated filling pressures, we do have probably signs and symptoms of heart failure as well. Well, one thing I want to show you is that global longitudinal function is very often reduced in patients with heart failure with preserved ejection fraction. So very often we have a reduction in the global longitudinal strain, which is depicted in this graphic. So again, we're at the question, why to measure diastolic dysfunction? Why to even bother? Well, of course, monitoring in an ICU setting helps to identify patients with need for volume or with hypervolemia, for example. Again, that already said, it's about prognosis, and we get ideas of why heart failure might be even present or why a patient is symptomatic when there's heart failure present. The filling pressures are something which is very important to understand, and we have to identify pathological filling pressures. And overall, the PCWP, so the pulmonary capillary wedge pressure, is equivalent to the LA pressure and the left ventricular and diastolic pressures if there are no mitral stenosis or pulmonary stenosis present. And the cutoff value is 15 millimeters of mercury. That will denote a significant problem and elevation in filling pressures. The left ventricular and diastolic pressure is also elevated when it's above 15 millimeters of mercury. And again, the left ventricular and diastolic pressure equals the left atrial pressure and also equals the pulmonary capillary wedge pressure if there is no stenosis in between those systems. Then we also have to know that there is a stress pulmonary hypertension present. The stress pulmonary hypertension is the mean pulmonary arterial pressure and the cardiac output slope. And there's an upper limit defined, which is pathological. So now we have some numbers. Let's continue with some more numbers. The diagnosis of pulmonary hypertension changed a little bit with the recent guidelines. It is now considered that the mean pulmonary arterial pressure of above 20 millimeters of mercury is defining pulmonary hypertension. When you have a pulmonary vascular resistance above 2, it is measured in Wood units, you have most likely a precapillary pulmonary hypertension or a combined form of precapillary and postcapillary pulmonary hypertension. When the wedge pressure is above 15 millimeters of mercury, it is a postcapillary form of pulmonary hypertension, or with a pulmonary vascular resistance above 2, it's a combined precapillary and postcapillary pulmonary hypertension. So it's very important to know and understand these measurements because we can also calculate them with some formulas. We will discuss them in a later stage. So the important cutoff for the wedge pressure is 15 millimeters of mercury. That would denote post-capillary pulmonary hypertension, so a left heart problem causing pulmonary hypertension, which is important in the case of HFpEF, but also reduced ejection fraction and heart failure, and multi-reduced ejection fraction and heart failure, as well as other left heart disease. For example, aortic regurgitation, aortic stenosis, but also mitral valve disease. So what can we do with echocardiography? Can we calculate those measurements? Basically, yes, we can. We can calculate all of those measurements with the help of echocardiography, more or less accurate, but that is a topic we will discuss. Important about the hemodynamics of diastolic dysfunction is that initially we have the elevated filling pressures, elevated left atrial pressures, leading to pulmonary hypertension, furthermore leading to right ventricular dysfunction and dyspnea, and adding in the long run also a degree of tricuspid regurgitation. So starting at the left heart, it is translated when you have elevated filling pressures into the pulmonary vasculature system and also into the right ventricle, and for that then causing symptoms. Patients feel uncomfortable. There are several reasons why diastolic dysfunction is present. So, of course, obesity, diabetes, hypertension, the remodeling of the heart, when we are talking about also HFpEF, heart failure with preserved ejection fraction. Aging also changes the heart. With aging, the heart becomes a bit more stiff, not necessarily elevated filling pressures are present. Of course, we said when we have a systolic problem with heart failure with reduced or mild-reduced ejection fraction, we have a diastolic problem as well. Furthermore, in dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, so also structural heart diseases, we will have a diastolic dysfunction problem. Coronary artery disease, left bundle branch block, pacing, valvular heart disease, and many, many more. So diastole, what actually is it? In the ECG, it's here displayed. It's the end, more or less, of the T wave to the start of the QRS complex. And when we are looking at the heart, we see that aortic valve closure until mitral valve closure, that's diastole. So the filling of the heart. You see the aortic valve is opening during systole. When it's closing, the mitral valve opens, and when the mitral valve closes, systole begins again. And for that, we have in echocardiography several time intervals we have to understand and we can measure in evaluating diastolic dysfunction. We have the IVRT starting before the E wave, then we have diastasis, then the A wave, and then the IVCT, the isovolumic contraction time, then systole. So diastole are several parts, and we start with the IVRT, the isovolumic relaxation time. You see it displayed in this slide, and this is a short time interval from aortic valve closure. We saw the aortic valve closing, that's the start of diastole, until the mitral valve is opening. And in this case, in this IVRT, in this short time interval, the left ventricle is in a relaxed state. There are no real volume changes. The valves are closed, so both valves are closed. It's before mitral valve opening, and the aortic valve is already closed. And it is present until the left ventricular pressure is below the left atrial pressure, and then the opening of the mitral valve occurs. And that results in left ventricular filling, the so-called E wave. That's the next part we are looking at, the E wave. The E wave is the early rapid filling. The left ventricle sucks volume in. It's about 80%, 70, 80, even 90% sometimes that filling happens in this early diastolic phase. Well, it is of course associated with the mitral valve opening. So if the mitral valve is closed, we are not yet in the E wave. The LA volume, of course, and the left atrial pressures, they fall. So the volume is sucked in, the E wave, the early diastolic phase. Following this E wave, we have a phase of diastasis. So in diastasis, there is almost no filling of the left ventricle. The pressures of the left ventricle and the left atrium, they are very similar. So there are no significant differences. This diastasis part, where there's no filling of the left ventricle, is happening, is of course heart rate dependent. So with a higher heart rate, this phase even might be missing. Continuing with the A wave. The A wave is now the atrial contraction phase. The left atrial pressures, they are rising just a little bit, and overall in a healthy heart, 20% of the total left ventricular filling is contributed due to atrial contraction. So the last of the blood is pumped via the left atrium into the left ventricle. And this is happening until the left ventricular pressure is above the left atrial pressure, and then the mitral valve closes. And the cycle begins again. Before systole, we have the isovolumic contraction time. So that's again, the mitral valve is closed. The aortic valve is also still closed. It's the early phase of systole. We remember the IVRT, the early phase of diastole. So the early phase of systole, left atrial and left ventricular pressures are the same. There is no volume shift, and the left ventricular pressure is below the aortic pressure. And when it changes, we start with systole. So the left ventricular pressures rise and contraction happens. Again, we take a look at the echo image. This is diastole, aortic valve closure until mitral valve closure. Now let's talk about some contributing factors. So here you see left ventricular filling is dependent on the left atrial volumes. Here are two examples of also left atrial strain. We will talk about left atrial strain in a greater extent, but I want to show you two images here, two loops. On the left-hand side, you have a normal left atrial volume. You have 22 milliliters per square meter. The cutoff is 34 milliliters per square meter. And you have a very nice way of seeing how the left atrium dilates, the reservoir phase, and then also contracts, the contraction phase. And that is all normal. So this is a normal left ventricle and a normal left atrium and a normal filling. On the right-hand side, you see something different. You see that the strain, the left atrial strain, is significantly reduced. Also, you can see that the left atrium is contracting differently. There's definitely a filling problem present. Overall, this seems to be atrial fibrillation, and we have a dilated left atrium. So it's mildly dilated, so to speak. It's around 37 milliliters per square meter. About the borders or the measurements we will discuss also later, what are the cutoffs specifically for those measurements. But you see already left ventricular filling is dependent on left atrial volumes and also on left atrial function. The next is also the LV suction is important to really have a good filling of the left ventricle. And in this case, we see the radial function of the left ventricle. We take a look at it on the right-hand side when we see the TE study with the mitral valve in the center in a transgastric view. So also the left atrial volume and the left ventricular suction are, of course, important to ensure that left ventricular filling is properly done. Now, talking about myocardial mechanics, this is something you can discuss in very large extent. Here we have an example of 3D echocardiography where you can see the left ventricle from the base to the apex in a 3D adenosine stress echocardiographic exam. And we have to understand that the contractor cardiomyocytes, they are connected and they build up basically the majority of the myocardium to form this interconnected network. This multi-layer architecture is responsible then for the contraction, but also the relaxation. And then when we take a look at different theories of how the heart is actually built up, we have to define several layers. We have, in this case, the possibility of 3 different layers, but they do not have strict borders. We have a subendocardial layer, which is rightward oriented, a midwall and a subepicardial layer, which are leftward oriented. And they create an outer helix and an inner helix and the midwall myocardium. This is very important to remember when we talk about longitudinal left ventricular function. Taking a step forward, when we have this subepicardial layer with the leftward oriented helical fibers, this creates 25% approximately of the myocardial wall. The apex has a torsion relative to the base of the heart. The midwall is rather prominent. It's made up of 59% of the myocardial wall thickness, which is contributed to this midwall fibers. They have a larger extent because of aging, so over time they become more. The circumferential fibers, they are parallel to the mitral valve and they are responsible for the radial contraction. Now looking at the subendocardial fibers, they are thin. They only make up for 20% of the myocardial wall, the rightward oriented helical fibers we discussed, and they are responsible for the longitudinal function, but also for the rotation of the heart. In the left-hand side, you see a very nice example of a very new technology, the 4D strain imaging. And this was a patient with a STEMI, an ST elevation myocardial infarction in the LAD territory. And you see that the overall strain, you see these blue areas at the apex, there's akinesia present. You see that here myocardial mechanics definitely not work normal. Continuing with a 3D data set in this resting study of the patient we have seen before, we want to discuss another model, the so-called Torrent-Guasp model. This model says you have basically one muscle band. They are made of helical and circumferential fibers. It postulates that you have one basal loop and two segments, an ascending epicardial and a descending endocardial segments, and you have this apical loop with a fixed apex. The descending endocardial, they are responsible for the longitudinal function, longitudinal shortening. And the apex rotation is clockwise, the heart base rotation is counterclockwise. Apex and base rotation, they always mirror inverted in systole and of course diastole. During the IVRT and the IVCT, apex and base rotate in the same direction. So overall in systole, we have an apical contraction counterclockwise, descending segment subendocardial versus the greater radius of the ascending subepicardial segment. There is less rotation at the base of the heart clockwise. In diastole, the apex rotates clockwise, the base counterclockwise. In the isovolumic contraction phase, we have the base and the apex rotating counterclockwise, the circumferential contraction ascending segment with contraction, but with elongation and narrowing of the left ventricle. In the IVR, so the isovolumic relaxation time, we have a base and the apex rotating clockwise, but there's no contraction of the descending and circumferential fibers. There's a recoil, ascending only a little bit of contraction. The left ventricle elongates and stretches, but just a little bit. On the left-hand side, you always see that there is a 3D imaging where you can also follow how the base and the apex do actually rotate. And continuing with those myocardial mechanics, the time in between contraction of the ascending and descending segments is a very short time. It's 80 to 90 milliseconds of shortening. This is then also post-systolic shortening if you have an ineffective filling in the descending fibers that shorten persistently in diastole. And this is also important when we talk about twisting and untwisting. In this case, 50% of the untwisting is inefficient. So now there was, I think, two different theories of how the heart is built up and how contraction works. The bottom line is that there are three contraction mechanisms. So we have a longitudinal contraction, a circumferential, and a radial contraction. It's like when you have the left ventricle and you wring out a wet towel. That's approximately how the left ventricle works. There's rotation, twist, and untwist. Therefore, a rotation, fiber shortening, inward motion of the myocardium with a reduction of LV volumes happens in all those planes discussed. The subepicardial fibers, they always have the larger radius, the way stronger than the subendocardial. They are lesser and smaller in radius. Then subendocardial, when both contract at the same time, of course. And the twisting and the uniform distributed stress of the cardiomyocytes and fiber shortening lead to an ejection fraction of about 50 to 60%. So it's very effective for only those 20% of shortening we see in strain imaging. Therefore, during systole, because of the twist and the deformation of this myocardial matrix, the energy is built up. And in diastole, we have this rapid recoil, the untwisting, the rapid relaxation with this also active diastolic sucking the E-wave into the left ventricle. And of course, the ejection fraction is a 2D measurement. Ejection fraction is a measurement of radial function mostly, so longitudinal function does not contribute that much to ejection fraction. Strain measures contraction, but no volume shift on the other hand. And of course, everything has the same limitations because it is a 2D measurement. On the left-hand side, brought you a nice image of a patient with heart failure with reduced ejection fraction in the biological mitral valve replacement with this abnormal inflow pattern, where you already can see how the inflow works. It works in the opposite direction it actually should be, and of course, rotation, twist, torsion is impaired in this patient. So the stroke volume has to be the same, of course, as we have in the diastolic filling. More filling and less output is simply not possible, and also vice versa. So there cannot be more output than filling. Left ventricular systolic and diastolic function is dependent on each other. There's an interdependence present. If one has a problem, of course, systole or diastole, the other one will also take damage. Diastolic dysfunction, just as a reminder, is always present when you have a reduced ejection fraction, or also a longitudinal dysfunction in diastolic dysfunction when you have, for example, a heart failure with preserved ejection fraction. Once more, to summarize, there are several theories how the heart is built up. Overall, it might be more complex than what we so far discovered. In the bottom line, we have those 3 different motions and contributors to actually left ventricular function, and that we have to keep in mind that there are possibly several layers. The endocardial layer, mostly responsible for longitudinal function in the left ventricle.